Good morning, everyone, and welcome to the University of Maryland Eastern Shore special virtual event, Black History Month celebration, reflecting back and looking forward on equity, COVID-19 testing and vaccination. The event is being held virtually today via Google Meet, and it's being recorded. Before we start, I would like to invite everyone to mute yourself to prevent echo, and also not to show video if you prefer not to be recorded. The session will be recorded for viewing later. It is my honor and pleasure to serve as your host and moderator this morning for the program here, and we have lined up a great panel of speakers that I will introduce them as they begin to speak with you. And I will start out with our very first speaker, Dr. Noah Brathwaite, and to share with you a very short introduction. Dr. Brathwaite has kindly said that he doesn't need much introduction because he wants to have the optimal time for speaking of the speaker. He simply wants to say that I've been introduced as an ambassador for reducing health disparities and achieving equity in Maryland, and he is very supportive of the effort of UMES in this war. With that being said, and without further ado, I turn right over to Dr. Noah Brathwaite to kick off our special celebration for today. Dr. Brathwaite.
Good morning, Dr. Traum, and good morning, presenters, and good morning to all of our viewers and listeners and all of our participants. It's a joy to be here on this cold and snowy morning, but I'm sure that there's a lot of happiness also in Maryland, across the Eastern Shore and southern parts of Maryland, also Western Maryland, Central Maryland, Metropolitan Maryland. So we want to welcome you to this event. I consider the topic reflecting back and looking forward on equity as a critical topic that can be addressed and give us some perspective. So in terms of the Office of Minority Health and Health Disparities, looking back, we were founded in 2004. And this was an act of the legislature at that time. And since 2004, we recognized that there was a building process that led up to that event of the legislation. And there were two remarkable studies that I considered to have been the foundation of the act to form the Office of Minority Health. And one was the Margaret Heckler study that dealt with the disparities in United States. And there were 7 disparities that were of note. And a number of those disparities still exist today. So that was in 1985, 1987. And then that dealt with the health component of health disparities and health equity. The other one was the healthcare study that was done in 2002, considered to be almost a hallmark study on equal care. The Institute of Medicine had asked for that study to be done. So those 2 landmarks I considered the 1985 study on health disparities and the 2002 study on equal care set the tone, I believe, for a greater focus, not just on health disparity, but also the need for health equity. Since 2004, the office has been driving a number of initiatives, and these were all driven by data. And I'm sure that following me, Dr. Mann, who is considered to be data man, he would provide you with that. But our efforts since 2004 have been driven by data. And these include data on chronic disease. Chronic disease also include things like diabetes and heart disease. And they tell us that there is an ongoing and persistent disparity existing. And we also have infant mortality as another health disparity area that we have been looking at. That would give us a sense of the background to the office and also the early start relative to health disparities across the state, looking at the geographic disparities, looking at the health condition disparities, looking at the socio-economic disparities. So this brings us to now COVID. Many of you know that one of the things that COVID-19 has done, is to showcase the disparities and the inequalities that exist in health and healthcare. And some people always refer to it as exacerbating those conditions, pre-existing conditions, and also the socio-economic drivers of those pre-existing conditions. So we are quite aware of the need to address and continue to address those highlighted conditions that were exacerbated by COVID-19. No doubt most of us would recognize that COVID-19 is another example of a disparity between a racial disparity of a condition. The future, I think, of health equity, to me, it seems to be very, very bright. Why do I say that? There are three reasons for saying that the future of health equity appeared to be brighter than in the past. One is the COVID-19 itself. COVID-19 has focused a lens on not only disparity, but inequality and the need for equity. And arising out of that, there are a number of efforts that we ourselves have taken. We are doing messaging and communication. We're also providing care packages across the state to help the socio-economic needs. And we are embracing the need for the HBCUs to become the fountain of knowledge of what is taking place among the African-American and other communities of color. So the HBCUs have been funded to provide us with some knowledge and of attitudes and also some directions that we should take going forward. So one is the COVID and what we have been doing to alleviate the impact, also the reach of COVID by bringing those three components together. The second reason for optimism is that it is a legislative reason, in that those of you who are following the Maryland legislation, proposed legislation, would recognize that there are a number of bills that have been drafted to put in place some more teeth for disparities and also embracing equity. So look at the legislation that would be done by April. And also at the federal level, as you know, there's a bigger emphasis now on equality, and that not only in terms of domestic policies specific as a broad umbrella, but health policies as a subset of that broader initiative to bring equity to the forefront of the country. So that's the second reason for optimism. The first was the COVID-19 itself and what is being done. And the second is the legislative mandates that would soon be a part of our landscape. The third reason for optimism is those of you who are here as presenters, in that you have dedicated yourself in the past, and you will continue to dedicate yourself in the future, I believe, through the relationships that you have built with HBCUs and through the academic institutions that we have in Maryland, and through partnerships that we trust, these trusted partnerships, in spite of sometimes we have, not sometimes, but there's a big mistrust that has enveloped the state and the country relative to vaccine. I think those three reasons for optimism will guide us into a better future. It doesn't say that we are going to remove all the vestiges of disparities and inequalities and then have a bright future where we are now in the vistas of equity. That is our goal, that is our aim. I hope that this morning, as we discuss different aspects of vaccination and testing and the COVID-19 and equity, that we position ourselves as an office to collaborate with not only the HBCUs, but those of you who represent other organizations. I believe that the agenda for equity is one that we all can embrace. The strategies will be different, but the outcome should give us a good indication that we are now on a greater gradient for equity in the state of Maryland and also in the United States. Thank you very much, Dr. Trong, for inviting me to give opening remarks. And I believe that equity is on a good foundation going forward.
Thank you so much, Dr. Brathwaite, for providing an open remark and a message of optimism. With that being said, I will now stop sharing my screen and invite Dr. Mann to share his screen as he requests to present while I introduce Dr. Mann. Dr. Mann, I turn the screen over to you as I introduce you for as our next speaker. So Dr. Mann is epidemiologist at the Office of Minority Health and Health Disparities at the Maryland Department of Health, 55% FTE. His other 25% FTE is spent as an instructor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. Dr. Mann received his Bachelor of Art in Biology from the Johns Hopkins University in 1978, his medical doctor from Harvard Medical School in 1982, and his PhD in epidemiology from University of Maryland, Baltimore in 2007. Before becoming to Maryland's epidemiology and public health training in 1998, Dr. Mann practiced primary care medicine in the greater Boston area for 14 years. Dr. Mann was a co-author of the Maryland Plan to Eliminate Minority Health Disparities, released in 2006 by Minority Health and Health Disparities Office. He is also principal author of the Maryland Chart Book of Minority Health and Minority Health Disparity Data, released in 2007, 2009, and 2012. He was part of the work group that created and developed the Maryland Health Enterprise Zone concept and served on the DHMH Health Enterprise Zone Oversight Team. He was also a major author and primary editor of the data section of the recently released Maryland Diabetes Action Plan. He's been an invited speaker on health disparity data several avenues. Please help me welcome Dr. Mann. I turn over to you.
Thanks very much, and I'm very happy to be here at the event. I'm not quite sure if the data I'm going to present meet the criteria of a celebration, but it's the data that we have, so we'll take a look at it. Hopefully everybody can hear me and see my screen, so definitely let me know if that's not the case. Moving on to the first slide, we're going to try to talk in the limited time we have about some health disparity data basics and emphasize the role of social determinants, look at some Maryland COVID-19 data by race ethnicity in the areas of case rates and testing rates, hospital admissions, death rates, and vaccination rates. We may have time to get to some data on disparity and some of the relevant comorbidities and how the social determinants interact with those comorbidities. This is a slide I like to use a lot thinking about data because it really allows us to think about a causal chain of health disparities and the framework of how we can actually see some of that in data. So over here at the far right, the ultimate outcomes we think about death rates, disability rates, and diabetes, we think about amputation rates, hospital utilization rates like admissions and ED visits, the cost of things. These are the things we'd like to see equal across different groups, whether it's geography, race, ethnicity, income levels, etc. These things are driven by two fundamental factors: the frequency of disease and the severity of disease. And you can almost multiply the cases per 100,000 people times the, say, deaths per case, and get over here the deaths per 100,000 people. So this is a very close relationship, and disparities can happen either in this box of frequency or in this box of severity, or both. And then each of these boxes then comes from two boxes. One is the prevalence of the causes of disease, and then whether you do or don't have access to good prevention services, and that'll determine how much disease is in that population. Then the severity of the risk factors and the access to treatment services will determine how severe the disease is once it's there. And then all of these factors emerge from a whole collection of social determinants of health. This is a partial list here, things like education, employment, income, etc., including racism, including all of the current and historical trauma that has resulted from racism in this country. And a lot of these social determinants are correlated with place. And so that's one of the reasons you hear phrases like place matters, or that your zip code is more important than your genetic code. So all these things here are where we have to do our interventions to start making a difference in all the steps of this chain. But we can actually look at data in different steps of this chain to see how we're doing. So then we have to also cut through data clutter. There's so many things, especially with computers, that we can do to produce tons and tons of data output. But what data produces the story, answers the question that we're really interested in? So sometimes race ethnic group data or any other kind of group data comes up. You get counts of things. Sometimes you get the percent each racial and ethnic group, for example, contributes to the total count. Or you can get the rate of the event per a set number of persons within each group. And oftentimes, because the population sizes are different for these different groups, these rates per 100,000, or sometimes it's a percent if it's big enough, are often the best way to show disparities, certainly by race, ethnicity, and often by geography. So also in this, we have to think about the role of time. We've had rises and falls, 3 peaks, 3 troughs. It turns out disparities have been larger in the peaks and smaller in the troughs, so we have to get a sense of what the time trends have been. And then we've got the challenge of how do we know things for sure? So we might have a very simple question of how many cases do we have, but what we know is the cases we found by testing, and we know the rate at which we're testing. What we don't know is how many cases are there in the people we haven't tested. So to some extent, the things we see aren't the whole story. And so if testing is going up, or actually if the positive cases are going up, how much of that's because we're doing more testing? How much is it because there's actually more cases in the community? So that's one of the challenges we have. On the other hand, whether we find cases or don't find cases, if people get sick enough, they end up in the hospital. So in some ways, the trend in hospital admissions is a really good indicator of what's going on in the case rate trend, with a little bit of a lag, 1 or 2 weeks lag in that. And that's not a relationship to whether we're testing more or less. So sometimes that's really good to look at, and I'll look at that a lot here. And death rates similarly don't really depend on whether you're doing more testing or less testing. That's going to show up regardless. So now this is a chart of the admission rate trend by race. So to orient you, the brown line here is the rate in Blacks and African Americans. The teal line is the white rate. The pink line is the Asian rate. Because of the small size of the American Indian community and the fact that the unknown data is actually many multiples higher than the American Indian data, we really aren't sure what to make of what we see in the American Indian population, so we haven't displayed that here. But in this case, you can see that the admission rate was really high at the first peak for the Black population and much higher than the white and Asian, which were pretty similar. Then the gap got smaller as we got to our first trough. Then we got to a second peak where it's really a bigger peak in the Black population than others. Then a second trough, and then our recent peak, where in fact the Black rate got back to its all-time high, but the white rate found an entirely new all-time high compared to the spring, and the Asian rate also got to a new all-time high. So we can see here that disparities have been different at different times in the pandemic, but we have had a consistent pattern where it's always been worse for the Black population. This is again what this same thing looks like looking at Hispanic versus non-Hispanic. The gold line is Hispanic and the red line is non-Hispanic. And here we can see that we had a great big disparity at the beginning in the spring. And since then, we've actually had a smaller gap overall in this. And here it looks like maybe the two rates have actually equalized a bit. We're going to see on the next slide, though, when we start to tease that out in separate age groups, this is a pretty busy slide, but I want to focus in here on the Hispanic number. You can see that what looked like a gold and red line that were pretty similar on the previous slide are actually a little bit separated when we do the age stratification. And that just illustrates that you often have to have some approach to age adjustment, whether it's an adjusted metric or a stratified analysis, to really see the full range of the disparity. Here, the disparities were pretty consistent across the different age groups and also similarly seen in the overall age total. So this graph takes kind of a summary of what the peaks and troughs were. So here we've got the Hispanic rate in purple, the Black rate here in black, the white rates in the red with the open white circles. And we can see by superimposing the Hispanic on the entire population here with the other groups together, we got race and ethnicity in the same chart, that the Hispanic rates initially were higher than even the Black rates. Everything got closer together as we got to this middle section during the summer and early fall. And then the Hispanic rate was still higher at our peak, but now it's actually come back to where the Black and Hispanic rates are kind of similar, and both of them higher than the white rate, which again is in the same range as the Asian rate. An interesting thing to note from this part of the chart is if we look at different disparity metrics, and here the ratio of Black to white or Hispanic to white, so here's Black to white, here's Hispanic to white in the open circles, you can see that the ratios actually have gotten smaller. Even in this biggest peak that we had, the disparity ratios were smallest, even though those minority rates were actually pretty high, the second highest of the whole pandemic. So sometimes you have to be careful because disparity metrics can actually get better even when the minority rate is getting worse, if the white rate is also getting worse. And it's this rise in the white rate that has made these ratio metrics of the disparity actually get smaller to hide the fact that the minority rates actually got much worse at this time. This looks at what happened to death rates, kind of summarized in the same way. So we see that the Black mortality rate was the highest, certainly at the beginning. Then at this stage here, it was actually a little bit higher for the Hispanic population. Then here it was again higher for the Black population. Everybody was kind of similar around the 20th of October. And then as we got back to our new peak, all the rates went up, and the crude rate, not adjusted for age, for Blacks and whites actually ended up pretty similar. But if we were to age adjust this we'd probably see the Black rate still be higher in looking at individual age groups. So it didn't have enough data to really do that age adjustment for this chart, but that would still have been an issue. So moving on to case rates, we can see that, again, the same construct where the brown here is the Black and African American and the teal is the white, pink is the Asian. Early on, the case rates were much higher for the Black population in both the first and second peak. In this latest peak, the white rates actually kind of caught up and were kind of similar to the Black rates in terms of case rates. So we can see that, again, different times in the pandemic, the racial ethnic disparity pattern has changed. This looks at one particular age group, 15 to 24, where there were actually parts where at certain times the white rate actually ended up higher than the Black rate. So that can happen from time to time, but certainly not the norm. So case rates are certainly a function of how much testing you're doing. And so we can see that testing has certainly been rising over the whole course of the pandemic. And we can see we've actually been testing the Black population a little bit more per 100,000 than the other two populations. So you could ask, are we under testing whites and Asians? And by looking at the percent positive, we can see that that's actually similar across the three groups. And so percent positive, I think, is really a good metric to tell you whether you're testing enough. It's less good, I think, as a metric of telling you whether your epidemic's under control. But here it makes me think we're probably testing people at about the right proportions, given the amount of cases that are in the population. Looking at case rates by Hispanic ethnicity, again, we see that, again, a high gap at the very beginning of the pandemic. Things got very close to each other toward the middle in the late summer and early fall. And then in our surge, we had a big spike. So in the non-Hispanic as well as the Hispanic, so the gap was smaller, not because the Hispanics did so much better, but because the comparison group did so much worse in the new wave. Again, testing, we can see that that's been rising over time, but here we see the testing is a little bit low for the Hispanic population in the goal, so we can ask, are we under testing Hispanics? So we look at the percent positive line here, and we see, oh, percent positive is actually higher for Hispanics than for the non-Hispanic population. That does suggest we might not be doing as much testing in Hispanics as we need to do. So this then is the cumulative percent of population that's been vaccinated by race ethnicity. And every once in a while, since these are cumulative numbers that don't change a lot, I go in and kind of pick a new update for the numbers. So we can see these kind of these three linear trends here. There's a line here for Native Hawaiian and another Pacific Islander, which is the highest and the fastest growing. I think that's a function of census probably doesn't have the right denominator for population in Maryland. I think we just are probably dividing by a population denominator that's half what it should be. So that's probably why this is here. We can see that the the white population and the Asian population, as well as the total for the state, are running on this trajectory, and then the Black population, Hispanic and American Indian, are all at this lower trajectory, which means they are going to be kind of consistently low if we can't bend these curves to be in a bit more parallel, if not advantageous trajectory for these lagging groups. So this is what we have to work on here. Now, another way we often see the data is presented as what percent of everybody we vaccinated is which race ethnicity, and this is where that stands currently. And so we often look and say, well, we might expect it should be 30% for Blacks and it should be 58% for whites because that's the total population. But it's actually a little trickier than that because we're vaccinating different age groups, different special populations. So the percent of the population in each racial group, if you look at 75 and plus and 65 plus, are shown here. So depending on how we're mixing vaccinating 75-year-olds, maybe a lot of them, and then some of the 65-year-olds so far, and some people who are high priority populations of multiple ages, somewhere in between this range is where that target equity rate is, but I can't tell you exactly where it is. So clearly the African-American population is below where it should be any way you look at it. The Asian population might be on target if this is the right reference number, but it's a little low if this were the target. The white population might be actually vaccinated a little too low if this is the reference population, but too high if this is the reference number. So again, we're not quite sure. And some of the problem is we've got 15% where we really don't know where they fit in here, and the population denominator doesn't have that uncertainty, and so that also affects all these numbers. And the Hispanic population could be on target if this is the reference number we should be shooting for right now, but if we really are thinking more toward this, we're obviously not quite there. So a lot of uncertainty in how to actually interpret some of this. Are we doing enough in all the groups? I think for sure African Americans are lagging, and I think we have to worry that Hispanic, Latino, and Native, and American Indian, Alaska Native are potentially going to fall behind if they're not already behind if we don't make special efforts. So in the interest of time, I'm going to jump over to my concluding slide after I hit this slide, Reasons for excess minority COVID events are usually a higher minority frequency, more incidents or more cases, coming often from more employment in essential occupations, less ability to telework, more likely to be in large, high-density, multi-generational households. And so you're more likely to bring it into your house, and there's more people to spread it to inside your house, and that can multiply the case rate pretty fast. Reasons for more severity include higher general stress due to violence, poverty, and racism, less access to resources due to poverty and racism, and a higher prevalence and severity of the comorbidities that matter, things like hypertension, diabetes, and asthma. So we'll skip over these and get to the concluding slide, the take-home messages. Social determinants of health are the root causes of disparity. Minorities tend to do worse at every social determinant of health level, and they're also more likely to be in the higher risk levels of the social determinants of health, so there's kind of a double whammy on minority populations. COVID-19 disparities are seen in case rates, testing rates, hospital admission rates, death rates, and vaccination rates. And factors contributing to disparities in getting COVID include more essential work, less telework, and the large high-density multi-generation households. Factors contributing to being sicker once you get COVID include poverty, stress, racism, and more comorbidities. And the poverty and racism and the social determinants of health disparities that result from those also contribute to the vaccination rate disparities. And with that, I'm going to conclude.
Thank you so much, Dr. Smain, for your insightful data. I appreciate it. In the interest of time, I will introduce the very next speaker, Dr. Freeman. While Dr. Freeman pulls up his slide, I will introduce him. Dr. Freeman is a social impact investor whose academic preparation, research, scholarship, and professional career are transdisciplinary and have converged at the intersection of public policy, healthcare administration, state, and on theological, ethical, and social issues in human genomics. He holds a certificate in community building strategy from the University of Baltimore, bachelor's degree in political science and public administration from the University of Dayton, and an MBA in Master of Divinity and a doctorate from Howard University. The focus of his doctoral research is theological and ethical dimension of the Human Genome Project. He's a continuing author of the book, Diversity in Human Interactions, The Tapestry of America. Please help me welcome Dr. Freeman. I turn it over to you. Dr. Freeman, you are on mute. And I should also add that Dr. Freeman chaired the Black Communities Work Group of the Mass Vaccination Outreach Planning Work Group, as he shared on the agenda. Dr. Freeman, I believe you're on mute. Oh, thank you. I think that. Yes, I can hear you now. Thank you, Dr. Freeman. Welcome.
Certainly. Thank you, Dr. Trong, and it's still morning. Good morning to everyone. It's a joy to be here with you today in the University of Maryland Eastern Shore as you share this Black History program around what's taking place with COVID-19 vaccination and equity. As Dr. Trong has mentioned, myself and a number of colleagues who are in ministry serve in the African American Clergy Medical Research Initiative, where we come from various disciplines, from public policy to theology, to the engagement with the science that is now creating precision medicine that's being applied in the work that's taking place now around COVID vaccination. And so we were invited to a Maryland State Department of Health work group where we joined approximately 94 other individuals from around the state to focus on mass vaccination outreach planning on a weekly basis. And so we have been engaged in this process since early November on a weekly basis to discuss various facets of COVID-19, to receive the data, such as we have heard from Dr. Braithwaite and from Dr. Mann, as well as to begin to strategize how we as non-government participants could also work with our state government in terms of strategies around communication and strategies around support of implementation. And so on February 1st, the Black Communities Subwork Group had an opportunity to present to the larger group earlier this month. And so it was decided that the group of 94 would be subdivided into these various work groups where we focus on the research that has been quite interesting, exploration that has been important to us, the planning, as it relates to executing strategies, somewhat challenging, and to the point of implementation, there is a lot of work that needs to be done around vaccine implementation, particularly in the state of Maryland. And so it was thought to divide the work group into 12 sub-work groups, and some under the ethnic group were divided even further. And so you have the mobile public health unit, education unit group that's focused on getting information disseminated through a mobile unit that one of the community partners that's a part of the larger group operates. Then to utilize particular community locations where we find a number of people on a consistent basis, such as barbershops and salons. And then another work group that focuses on public gathering spaces, another that focuses on kits and essential supplies, another that focuses on special needs populations, and then the ethnic or ethnic-centric work groups, of which there are several, Asian American, Latinx, and then the Black community subgroup, which I'll share a little bit more about in a few moments. Virtual town halls, historically Black colleges and universities, such as the University of Maryland Eastern Shore. And so we've been privileged to meet with Dr. Trong and have engagement with him in our sub-work group activity. Data analysis, those who are advocates, information sheets and flyers, how do we disseminate information, as well as a group that's focused on the clinical mobile screening unit for the testing. And the subwork group that I'd like to focus on is the one that we are currently engaged in, Black Community Subwork Group, that has been together since the first of the year. We are gathered and convened under the direction of Dr. Mark Martin in the Office of Minority Health and Disparities. And we have a liaison who also works with us in the person of Mr. Calvin Johnson. I've been fortunate to serve as the lead of that group. And we have a number of persons, I believe we're a committee of 17, of which Dr. Trong is a part of our group, as well as Ms. Valerie Davis, who you'll hear from in more detail around our particular activities and presentation. And so as a sub-work group that focuses on Black communities, we have identified that in Maryland, Black communities represent 29.5% of the population, but we find that we are overrepresented in COVID-19 deaths at 34.5% at this particular point in time, and that we are underrepresented in COVID-19 vaccinations at this point in time at 14.9%. And so we know that there is definitely a need for equity as it relates to this process. And so our observations and experiences, one, that the Maryland Department of Health and the Governor's Office are really challenged and neglecting. Many of us are saying that our state's hardest hit communities, that African-American communities are being adversely impacted. And so as we look at the data and we talk the numbers, we are reminded each time that we gather that nearly 4,000 persons per day are dying from this pandemic across these United States. And so while we're looking at the data, it's now time to move towards action and implementation. And so to date, our work group, we've held four team meetings, and we've added individuals from across the state to help us in this regard, that come in various disciplines, that we come from regional diversity, Western Maryland, Eastern Shore, Central Maryland, rural Maryland, urban Maryland, so that we get the input of everyone from around the region as it relates to how they are being impacted in the Black communities across the state, as well as institutional affiliations and related missions. We decided early on, these would be our guiding principles. One, that we are data-driven, and we were receiving data on a weekly basis, such as you heard from Dr. Mann during our larger work group meetings. So we are data-driven, and we are equity focused. This is going to be paramount if we are going to see a speedier resolution to vaccination throughout the state of Maryland. And so we're timing our work based on the fierce urgency of now. The Reverend Dr. Martin Luther King Jr. Spoke to this regard, that now is the time to do what we must do in order to see the results that all of us desire to see. And so there's 7 target deliverables: community engagement, community priorities, influential messages, influential messengers, proven delivery channels, research agenda, and success metrics and measurement. And so we have submitted a couple of reports from our sub-work group to the larger work group leadership that is being moved up the channels through the state of Maryland leadership. And so we're requesting the advanced timing of deliverables. There was initially a discussion that we would get around to talking about these things in March, but the time is now that we would apply an equity lens to all the COVID-19 related efforts. And so my colleague, Valerie Davis, will give us more information in that regard, and that we wanted to advocate at the county, state, and federal levels for immediate adjustments to vaccine rollout criteria. As I said to you earlier, when we began to get information as a large work group around the research, extraordinary research, and then the explorations, the discussions were very promising. The planning has been very challenging to the point where there have been instances where we believe that there are some folks in our government that are at least tone deaf, where they're not hearing the particularities that are necessary to help Black and brown communities to move towards the yes for vaccination. And so we have tried to explain that we should be normalizing vaccine hesitancy because there are reasons that persons are responding in the manner in which they are, and that people will respond to persons who are trusted advisors close to them, not necessarily notables and luminaries around the state or on the national scene, but people talk to their family, they talk to their clergy, they talk to other leaders of institutions in which they are affiliated. And if they receive positive insights from those persons, there's more of a proclivity to engage in embracing the need for vaccination. And so we are asking to invest in a centralized system for vaccine registration, because right now things are based on a county basis, and there's a lot of or a lack of continuity associated with that process. To fund, empower, support local health departments to lead the way in partnership with grassroots organizations that know their communities. As of late, we've been hearing a lot of information from our state government leadership that we're creating these mass vaccination sites. So we've created a site at the Baltimore City Convention Center. We've created a site in Prince George's County at Six Flags facility. And we're hearing the discussion about creating another site at M&T Bank Stadium where the Ravens play. And there's also a site, I believe, up in Timonium at the fairground. But what we are saying is that it's important that we also have a community-based strategy, a local strategy for those who don't necessarily have the wherewithal to get to these mass vaccination sites very easily. And so churches and other community-based organizations and centers can serve as support mechanisms to help accelerate the vaccination within our communities. They are trusted spaces, they are trusted places, they are very easy for many in our community to walk to. And so we're hopeful that this strategy will be considered and embraced sooner than later. So there are several other activities that are taking place with the Black Community Sub-Work Group. And so our ask is to shift the current messaging elements immediately and consist with existing research and best practices, starting with our state leadership. We want to normalize, not criticize vaccine concerns. And we want to establish responsible, data-driven, consistent, and trusted generated messaging, starting with the governor's office. I know it sounds, kind of racy and maybe kind of cute, and you might be able to remember it about wearing the damn mask. Let's stop damning the mask. The mask is the most critical thing that we have until we can become vaccinated. And so we need to give emphasis to the fact that wearing the mask is absolutely critical. And so the messaging has to be important. And so we want to be intentional to coordinate messaging and plans, not only with the federal government and the state of Maryland and the counties and the cities, so that we have a continuity of messaging, a continuity of process that will accelerate vaccination throughout the state of Maryland. I thank you for your time and allowing this opportunity to participate and share in this important event. Thank you so much.
Thank you so much, Dr. Freeman, for sharing the update, as well as leading the effort with the Black Communities Work Group. It is a pleasure to serve with you. With that being said, I would like to transition to our next speaker, panelist, Ms. Valerie Davis, while she bring up her slides. Valerie's heritage is rooted in a family full of African-American preachers, teachers, and entrepreneurs, with parents who were Mississippi tried civil rights advocates of the 1960s. She brings a relentless pursuit of justice for humanity to her work on behalf of women, children, and Black communities around the world. Her work as a founder of the notable for-profit Blossom, Incorporated in the Vineyard, helped girls and women to discover their gifts and talents and pursue their unique purpose. She volunteered with 5 Montgomery County Public School recovery work groups because she is that parent, that the engaged, informed advocate who advocate on behalf of every child. Her answer to catastrophic pandemic-driven losses in Black community was to convene a group of phenomenal Black women to save and uplift Black lives by offering workforce development and public health service. Elevate Her Incorporated is a not-for-profit organization that takes women of color off the front lines and unemployment lines and train them to deliver public and community health service to their communities from the safety of their homes. Contact Pros advise private and public entities on COVID-19 preparedness and provide culturally competent contact tracing service. Please help me welcome Ms. Davis.
Thank you, Dr. Trong, and thank you, Dr. Freeman, for laying out the groundwork and the backdrop for this conversation. I'm actually going to do a little storytelling and in the context of Black history, but very personal Black history. So I want you to prepare to go on a little bit of a journey with me. So let me tell you a story. I don't know how many of you have actually seen a bill of sale for a slave, but that's what this is on the top left side of this slide that you see here. It hangs in what is now my daughter's Zoom classroom. It used to be the dining room, next to this sign that says no dogs, no Negroes, no Mexicans, and colored are served in the rear. It hangs there to remind us of the story of our history and our opportunity every day to make a different kind of history, but it's standing on the shoulders of the people who brought us to today. And the people who brought me to today are my parents. Dr. Trong mentioned a bit about my background in the introduction, but who you see here on the left, that's my mom when she was 6 years old. And if you saw a 6-year-old picture of me, I look just like that. Next to that picture is the one-room schoolhouse that educated every level of child in the country where my father grew up. They're both from Mississippi. They both came from what we call the country. And this picture includes his sisters, his brothers, his cousins. And over here on the right, this old man and this lady with her arms folded, those are my grandparents. You might wonder, why are they in the one-room schoolhouse picture? You know, the teacher's there sitting in the middle. But I'm that parent because they were those parents. They were important enough and supportive enough of the school that when it came time to take the school picture, not class picture, but everybody, they had to be in it. And this is the stuff that I'm made of. This is where we come from. And so Reverend Henry Carmel Island, who was a preacher from the time he was a teenager, went on to play football and become an All-American football player at Jackson State in Mississippi. And there he met the lovely Orderly Green Island, who decided she wasn't going to clean house or take care of white folks' babies. And so she needed to go to college. And her father, without a dime in his pocket, without a job, my grandmother, his wife, without a job, without education, didn't finish, because in the country you had to go in the field and work. Her father decided to move from the country to the city in Jackson, which was a phenomenal shift in the path to our history. What that did was allow them to go to schools that were better with books and with education, and eventually go to college, where they met. My dad gave my mom a lollipop in math class, and that was all she wrote. And she went at 16, and they were married for 54 years. But I was born, there I am in all my glory, December 4th, 1964. I'm the second of three daughters. My older sister and my younger sister are much more beautiful and brilliant than I could ever be. But that's the beginning of the story. And where we're going, I want you to think about a number. And if you know what these numbers mean, throw them up in the chat. The first number is 38821, 38821. And the second number is 339. And I'm going to tell you by the end of my little presentation what those numbers mean. But we have to start with the fundamental question of what is equity? And in particular for African Americans. Some of you may not know that Black History Month really is about focusing on the history in this country of African Americans in particular. And African Americans have a different and unique experience in this country than other Black people in Black communities. So it's important to put on the lens. And what I want you to think of yourself as the little girl who was born in 1964, and just put yourself in my shoes for a minute. And then you grow up and you hear people talking about equity and equal rights and civil rights. And you say, well, what does that mean? I looked up the definition and I like these things: fairness, impartiality, honesty, integrity, justice, fair play, decency, and goodness. And what it doesn't mean is when things are out of balance. So you grow up in a world where your parents had to drink at the colored water fountain. And my mother said, I don't want no colored water. And she would sneak, and at the risk of her life as a child, just to drink from the white water fountain because she thought she had a right to. And you wonder now, going forward, how can I create a world where my child can have better? And so the story continued, and I went and got a bunch of alphabets behind my name from all these schools, including Montgomery County Public Schools, where I went to elementary, middle, or at that time it was called junior high school, and high school. Not only did I get the alphabets, but then I worked for a bunch of companies, Fortune 50 companies, and then became a bit of a serial entrepreneur, which has me today as a partner in a Black wellness movement called Being Well While Black, a play on words. The words, sleeping while Black, walking while Black, jogging while Black. But important to this effort, Elevate Her, where we help women, Black women in particular, to come all out of the dangerous hard spaces, up their technology skills, put them back to work at home where they can Zoom with their kids to do public health work in their communities, saving Black lives. And then Contact Pros actually puts those women to work doing contact tracing and COVID-19 advisory services. So the story continued, but here we are today. Equity is still elusive in 2021, and that's putting it mildly, even in a pandemic. And these are just some of the headlines. I'll just let those words sink in. Blacks 3 times more likely than whites to get the disease. More than half of Black-owned businesses, they're gone. The number right now at that time was 41%. They're gone, they're dust, they're over. Women of color, hardest hit by pandemic joblessness and having to make a choice between, can I help my child not fall into the achievement chasm, or do I get to go to work? And all of this happens in a context that we must realize, right? It doesn't happen on its own. We can't discuss COVID in a bubble. It happens in a world where a dying declaration of a Black doctor is that she is not believed about what is happening to her. That's Dr. Susan Moore. You won't hear me mention Tuskegee because we don't have to go back that far to find absolute stark evidence that even when we have the so-called qualifications of society, Dr. Susan Moore had them, we are not believed to our peril and our death. And it happens in the context of what's happening politically, the inertia we have about moving forward on things that are right and true and just. So when we go out and we say we want people, whoever the we are, to trust us, all of this is happening and Black people are processing that. Moreover, structures that we have, particularly in public health, reinforce these inequities and disparities. Testing volume is declining. Why? Because we're not emphasizing it. We like what's popular. We like what's hot. We like what's interesting. We like a Superman saves the day with the vaccine approach. It's part of the American ethos. But the bottom line is, if you don't test, you can't track. And there are too many people who have to wait in line for us not to be emphasizing testing. Moreover, contact tracing has fallen off. Look at the bottom chart. That first number, that's how many people we had a phone number for in Maryland from the beginning of the pandemic, 352,462. But only 209,000 have a completed interview. We only know 209,000. Look at the difference in that number. Why aren't we doing more tracing? I can't explain it. My company has talked about it. We've talked about it in the Black community sub-work group. All the rage is the vaccine, but it's not available. These things are available, testing and tracing. And over here on the left side, I want you to think about this. You've heard of Operation Warp Speed. But when you're solving any problem, speed favors certain people. Those who have background knowledge of what you're being speedy about, those who already have access to and understand the information and the subject matter, those who already have the relationships, either to be a service provider or to get access to the solutions, those who have advanced English and comprehension skills, those who have time to move quickly, and those who have the personal bandwidth in this season of multiple stressors to process the need to move quickly and to physically be able to do it. Those who have access to the right technology, and then those who have a safety net, the backup plan. You know, when you think about conversations about the minimal side effects and the infrequency of reactions to in children or who contract the disease, or in people who get vaccinations, that doesn't really matter if I don't have good insurance, if I can't go to the doctor, if I don't have sick leave to take off just in case it happens to me. So the calculus for people in a movement of speed is very different if you don't have these things in place. Furthermore, inequities and disparate impact are known and ignored in public health. Known and ignored. This is a chart, and it references something that Dr. Mann talked about, the need to age adjust, because populations that are non-white tend to be younger. So when you age adjust for the incidence of this disease, and you look at the difference, which is this scale on the left, between our percentage in the population in the United States, this is the whole country, and the percentage of people who are dying from this disease, look at these purple bars, which represents Hispanics, and look at this dark teal bar. At every age category, we are disproportionately dying at astronomical rates. And look at this gray one. White people are disproportionately not dying. We don't want anybody to die, but this is known data from the beginning of the pandemic. Why aren't we acting on it? Furthermore, vaccination plans ignore and increase disparate impact. These are vaccinations across the state of Maryland on this top bar by race. Look at the bar for Blacks and African Americans. And then look at the second one on the bottom for Hispanics and Latinos. Why is that happening? We're happy to report that we are disproportionately impacted by the disease, dying by the disease, but we're not willing to put Black folks and Latino folks at the front of the line. This is a matter of will. This is a matter of putting the fear of backlash from whites behind us and letting the data really drive us. There are no phase 1 criteria based on race, ethnicity, or comorbidities that are being applied. Why is that? That's a decision. So when you look at public health structures and ask yourself, look, I just listed all the things that we're doing. We have a government-run military-style operation, and we're using terms like war, warp speed. We're putting people at the head of the Maryland Equity Task Force who have military backgrounds. Does it not occur to anyone that communities of color don't have great relationships with the military and law enforcement for good reason, particularly right now? It's tone deaf, as Dr. Boyer said. There's no coordination. There's no centralized registration. And look on the right side. What we're doing to get a vaccine is technology dependent, transportation dependent, time dependent, language dependent, and health dependent. Meaning you have to have the health and the stamina to do this Hunger Games Act to get a vaccine. Now, I don't know if you saw yesterday, there's a 90-year-old woman in the news who walked 6 miles round trip to get a vaccine in the snow. And they call it a shot of determination. Not only should this not be necessary, but it glorifies the fact that we have to make Herculean efforts, even white folks, to get a vaccination. So if white folks have to do that, what do Black and so-called brown people have to do to even know about this when we built a system that looks like it's designed to keep us out? So what have we learned and applied from the past? Those of you who are around at any level to know how we muddled our way through the AIDS crisis, we should learn from what we did before, particularly in the public health arena. These diseases and their progressions aren't actually that different, but we're not applying what we know. And that's what this slide talks about. So when you sit and look at the promise that my parents had for me, and I look at what I checked all the boxes to do what society told me to do, to fit in, to progress, to be qualified, to be available for opportunities. And I sit and I look at a system that seems like it's designed not to learn from what we've done in the past and not to embrace me as a life worth saving. The question is, how will our story end? And what will we teach the world about whose lives truly matter? This is my daughter. She's downstairs Zooming. She's 13 years old. She turned 13 in a pandemic. She became a teenager. She started high school. I asked you about the number 339. She has 339 days and counting in quarantine. How will this story end for her? What promise is there for her? Now, I was raised in a household where you don't come up with a problem unless you propose a solution. And we've proposed many, as Dr. Boyer has shared on our Black Community Sub-Work Group Committee to the Maryland Department of Health. But here's what you can do. There has to be a so what to this presentation. You can adopt an affirming lexicon that is scientifically useful for public health work in Black communities. Let's revisit and maybe throw out words like minorities. We're not minorities. In fact, we're the new melanated majority. Let's throw out words like American Indian. Let's throw out words like lagging groups. Let's throw out words like BIPOC acronyms. Say our names. Science demands that we use terms that are scientifically valid and valuable. Let's lead in this moment. We can bring our shared emergency, urgency, and passion into all of your spaces. This is not an antiseptic conversation. You should be upset. You should be mad. You should be scared. And you should bring that into the conversation because that turns up the heat to make things happen. You can't cook without heat. And we need to be cooking right now with gas, as they say. Thirdly, let the data lead. The data are clear. Let's not be scared. And let's be courageous in equity work to let it lead us where it leads us. And in this moment, Black and brown folks have to be prioritized. And then finally, do what equity demands, even if it's inconvenient. It's inconvenient to say Haitian American, Nigerian American. It's inconvenient to list all our countries and cultures of origin, but it's respectful, it's right, and it's scientifically valid. It's inconvenient to try to figure out how to use the right Spanish words in the registration system the first time so that people of Spanish-speaking origin can understand how to register. It's inconvenient to put boots on the ground to go knock on old folks' doors and say, Miss Jones, are you interested in signing up for a vaccine? It might be inconvenient and expensive, but it must be done. So I'll end with this quote: the ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy. And I'll end with my number. My first number I gave you, did anybody know what that was? 38821. That's the number of Black people that have died in the state of Maryland from COVID. 38,821. Thank you.
Wow. Thank you, Ms. Davis, for an inspiring presentation, especially to, we have many young students in the audience also. I know we're running a little bit behind on time, but I would like to invite you to stay on a little longer to support our student if possible. Our next presenter is Ms. Edequin Manzo. She's a student pharmacist at the University of Eastern Shore with anticipated graduation of May 2022. While at the university, she served the school through different student organizations, including the Student National Pharmaceutical Association, as the president, and the American Pharmacists Association Academy Student Chapter. Through these organizations, she renders service to the community by volunteering activities such as Adopt a Block Food Drive, COVID-19 testing, and vaccination. Ms. Manzo was born in Cameroon but migrated to the United States in 2012. She studied and obtained her Associate of Art in Montgomery College, where she also did pre-pharmacy course and earned a Frank Severity Physics Award for academic excellence. She lived with her sister and nephew, and they enjoy spending weekends telling a story, eating, talking, and walks. And with that being said, please help me welcome Ms. Edequin. She's one of our star pharmacy students.
Thank you. That pin doesn't match a meeting that's ready to start. Enter the meeting pin followed by the...
Ms. Edequin?
Can you hear me?
Yes, we can hear you.
Oh,
yes.
I'm sorry. My computer is having some technical difficulty. Dr. Trong, can you present my slides, please?
Yes, I can. I will bring up your slides for you. Please bear with us. I think she has a little computer signal challenge, but I will share a slide on for her. Right. Can you see my slide okay?
Yes, I can see it now. Thank you so much.
You're welcome. Sure. Okay.
Thank you, Dr. Trong. Thank you, everyone, for giving me the opportunity. I just want to take a few moments to talk about SNAFR. Again, I'm the president of SNAFR on our UMES campus, and our mission is to plan, organize, coordinate, and execute programs geared towards the improvement of health, education, and social environment for minority communities. Our goal is to serve the underserved population, and our role is to develop minority health professionals and vital members in the healthcare team. So basically we have a lot more, but mostly focus on helping our minority healthcare members. Next slide, please. So here are the various initiatives through which we serve the public. I would like to highlight the immunization operation right now. We are in the middle of a pandemic, and it's seeming that the only way out is to get immunized and join the fight against the COVID. So I want to thank our professors very much for sending out the emails to help us students join in the fight against COVID. And I'm encouraging every student that whenever you see this email, please sign up and participate in the fight against this COVID, so we can eradicate it from our community and go back to living our normal lives again. I'm pretty sure we all miss that. I miss it too, and I want to go back to it. So please join in the fight and help fight this disease. Next slide, please. So here on our campus, I just want to highlight our leaders, with our advisor being Dr. Noniel, and every other person who participates to help us carry out our activities smoothly on campus. Next slide. So how do we celebrate Black History Month through SNAFR? So Black History Month, February, we dedicate this month to highlighting individuals who have contributed positively to the development of medicine in our country. And I just have a few of them that I would like to talk about in the next slide, please. So starting with the women, we have Mary Mahoney, the first African-American nurse who created the National Association for College Graduate Nurses, NACGN. And because of her efforts, now we had a lot more African-American nurses joining the program from 1910 to 1930. Next is Dr. Amayo Stella Adadeva, and she is an endocrinologist working in Nigeria right now, and she was one of those who helped to fight against the Ebola virus when it broke out in Nigeria. Next, we have Dr. Dorothy Lavina Brown, who is a medical pioneer, educator, and community leader. And she's the first female African-American appointed to the general surgery resident in the de jure racially segregated South. And this is very close to me because she's a pharmacist, and it's the reason why most of us are in pharmacy school today. Anna Louise James, she was the first African-American female pharmacist in the United States. And because of her, most of us have been encouraged to go to pharmacy school. And fifth, we have Dr. May. She didn't contribute to medicine, but as a female first Black to go to space, that is important. Being that women are oppressed more than men, that is a big thing. Now going to the men, and there was no bias going from women to men, it's just. So going to the men, we have Jose Celso Barbosa. He was known in history as one of the first African Puerto Rican descent to earn a medical degree in the United States. The second, we have Dr. Fitzabelt Marius, who was part of the team that performed the first open heart surgery in Frenzo in 1958. Third, we have Dr. Solomon Fuller, who was the first African-American psychiatrist and one of the Alzheimer's research pioneers. And we also have Dr. James McKenzie, who was the first African-American to earn a medical degree and practice medicine in the United States. And I always leave the best for the last. Dr. Cooper, he was the first African-American to go to pharmacy school. And again, he is one of those that have opened the way for us in pharmacy school too. He's one of the people that led the way to get us into pharmacy school. So we celebrate these individuals for all they did, and because of them is the reason why most of us are where we are today. I also want to thank Mr. Hera Hill for putting this together, and this is part of what we do during the Black History Month to celebrate the minority. So we share this with our social media, and we share it with others just to create awareness of what we have done in the past. And to end this, I just want to thank everybody, thanking Dr. Trump for giving me the opportunity. And if you have any questions and you want to know more about SNAFR on campus, you can reach out to me. My email is there, or if you want to know more, you can go to the SNAFR website at snafr.org. Thank you.
Thank you so much, Ms. Eloquent Manso, for sharing what you celebrate. While I teach students, I continue to learn from students every day. It's very enlightening. Thank you for sharing. Last but not least, we have a panel of pharmacy residents and several students. Also, I want to invite Dr. Chloe Ann, who lead the effort of student interprofessional student in different health professions, to share with us a poster presentation pre-recorded on vaccines. Dr. An, could you please bring it on? Thank you so much, all students, for your support of Ms. Eloquent Manso. We'd love to see all of you as future leaders also.
Dr. Trump, could you stop
Yes.
presenting so then
Yes.
I can pull up the video?
All right, let me stop presenting.
Okay, thank
All
you.
right. Yes. For more information on SNAFA, you can go to the website that Ms. Manso shared with us. After the presentation, I will also email out to all registered attendees a copy of this poster, and in fact, I will try to do it right now also, that Dr. An led several students from pharmacy to physician assistant to also to medical. I turn over to you, Dr. An.
Thank you. Myself and all of the other presenters introduce ourselves in the video, so I'm gonna go ahead and start the video. Hello, everyone. Thank you for joining us for this presentation. My name is Chloe An, and I'm the community pharmacy resident at UMES and Apple Discount Drugs. Today, we have various presenters from UMES School of Pharmacy and Health Professions and the University of Maryland in Baltimore. Our presenters are current pharmacy, medical, physician assistant school students, and our topic for today is update on COVID-19 vaccinations. We will begin with an introduction from each of our presenters, and then we will begin this presentation.
Hello, everyone. My name is Jimika Akinola. I'm a current University of Maryland Eastern Shore School of Pharmacy P2 student.
Hi, everyone. My name is Tiffany Azo. I am currently a student at University of Maryland Eastern Shore as a physician assistant student, class of 2022.
Hi, my name is Megan Barnes, and I am a physician assistant student, class of 2022.
Hi, my name is Dahlia. I'm a medical student. I'm a third year at the University of Maryland, Baltimore.
Okay, we are going to start off with the types of COVID-19 vaccines. There are mRNA vaccines, there's protein subunit vaccines, and vector vaccines. mRNA vaccines such as Pfizer and Mrna are mRNA vaccines, and they are new, but they are not unknown. Scientists have been studying mRNA vaccines prior to COVID-19, and COVID-19 has been the first RNA vaccine established. They are not a live vaccine, and they also do not enter our human DNA. The mRNA gives our body directions to make something called a spike protein to create immunity in your system. Also, a protein subunit vaccine, such as the Nova vaccine, is also a COVID-19 vaccine, and it contains harmless particles of a virus that's injected into the body. The body realizes that it's foreign and will fight against it. And lastly, the vector vaccines, which contain a weakened aspect of a live virus, also attempts to fight off the vector and remember how to fight it in the future. This is something like the AstraZeneca vaccine.
So currently we have 2 vaccines in the US that are approved by the FDA for emergency use, one from Pfizer-BioNTech and one from Moderna. The Pfizer vaccine is given in 2 doses of 0.3 milliliters each at 21 days apart by intramuscular injection. The Moderna vaccine is also given in 2 doses as well, but in 0.5 milliliters each, and given 28 days apart by intramuscular injection. It should also be noted that these are minimum days that the 2 doses should be set apart. There is no maximum interval between the first and second doses. The 2 vaccines also differ in storage requirements. The Pfizer vaccine needs to be kept at a temperature that's much lower than normal freezers at negative 112 Fahrenheit to negative 76 Fahrenheit. Normal freezers are kept at about 0 degrees Fahrenheit, so the storage for Pfizer vaccine requires the use of a special freezer. The Moderna is kept at negative 13 to 5 degrees Fahrenheit and therefore can be kept in a normal freezer dedicated for vaccines. The Pfizer vaccine is approved for use in patients 16 years and older, while the Moderna is approved for patients 18 and older. The reason for the age difference is that when the EUAs were approved, the emergency use authorizations, the Moderna was only studied in patients 18 and older, while the Pfizer was studied in ages 16 and older. Since then, there have been other studies that began looking at both vaccines in younger children, but these studies are still ongoing and there's not enough evidence available for use in children currently. The Pfizer vaccine also has an efficacy of 95% in preventing symptomatic COVID-19 infection, while the Mrna has an efficacy of 94.1%.
The Pfizer and Moderna vaccines both have a lot of similarities, although they might have a few differences in how they're administered. Whichever one is available to you, you should go ahead and get that one. A lot of the ways that they are alike is that after they're prepared, they all have to be used within 6 hours, which is why sometimes on the news you might hear stories of people being in the right place at the right time, and because we don't want to waste any of the vaccines, they try and use all of the ones that are available. Also, once they are thawed, they cannot be refrozen and reused again. The vaccine does not have any preservatives, eggs, or latex, so anyone who has had a history of allergies to those things should be okay to get the vaccine. It should be noted that you should be cautious if you are someone who has had a history of a severe allergic reaction, such as anaphylaxis, where your throat is closing or you have trouble breathing, that kind of allergic reaction. And for that reason, we ask patients after they get vaccinated to remain in the area for 15 minutes to be monitored. And in some places, they actually have patients who have had severe allergies before wait for 30 minutes just to be extra cautious and make sure that they don't have any kind of allergic reaction to the vaccine. Where the vaccination is distributed, there should be some medical personnel on site just to be safe, as well as having EpiPens available in case anyone needs an EpiPen shot to prevent a severe allergic reaction. Some patients tend to have some adverse reactions to the vaccine, which can present as flu-like symptoms, maybe some muscle aches, some fever, some joint pain. A lot of people have pain at the injection site. All of these different reactions are normal. Some patients do get some of these symptoms, some patients don't get any. Every person is different, so everyone kind of reacts to the vaccine a little bit differently. But those people who do get symptoms like that, that can be expected, so nothing to be too shocked by. And people tend to have a little bit more reaction with the second dose than the first, but then again, everyone's a little bit different, so it could be different for you. One more thing to note is that all patients who are planning to get another vaccine after the COVID vaccine, like say you still need your flu shot or you need your shingles or pneumonia vaccination, after receiving the COVID vaccination, they should wait 14 days or 2 weeks in order to be able to receive any other non-COVID vaccination.
So currently in Maryland, we are distributing COVID-19 vaccines to priority groups based on relative risk of exposure or to developing a serious illness. And right now, Maryland is currently in phase 1, which is where essential workers in such locations as lab services or postal services are receiving the vaccine. And per the chart that's provided, we will be heading into phase 2 next, which is where adults that are between the ages of 16 to 64 that are at an increased risk of severe COVID-19 illness due to comorbidities, or essential workers in critical utilities or transportation, food services will be receiving the COVID-19 vaccine. And then lastly, we will go into phase 3 where the general population will receive the vaccine. Vaccinations are currently available through hospitals, local health departments, and pharmacies. And if you are eligible to receive a vaccine, you can contact your provider as indicated, and you will have to schedule an appointment since it's only appointment-based because of the pandemic.
There are 3 vaccinations on the way: AstraZeneca, Janssen's, and Novavax. AstraZeneca is an effective monoclonal antibody that can prevent COVID-19, particularly one that is long-lasting and delivered by intramuscular injection. May be particular use in certain groups. This includes people who have a compromised immune function, those who are particularly over 80 years of age, and people who have undergoing medical treatments that preclude them from receiving the COVID-19 vaccine. Janssen's, which is a part of Johnson & Johnson, is an investigational COVID-19 vaccine developed by Janssen Pharmaceuticals, which appears to be safe and effective at preventing moderate and severe COVID-19 in adults. According to an interim analysis of phase 3 clinical data, the vaccine only requires a single injection and can be stored in a refrigerator for months. Novavax, the third vaccine that is underway, has local and systemic symptoms, followed for 7 days post-vaccination. The symptoms are headache, fatigue, and muscle pain and weakness. After the Novavax has 2 doses, which are given 21 days apart. After the second dose is given, no vaccine-related serious adverse effects has been reported.
All right, so that concludes our presentation for today. Thank you to all of our presenters, and thank you to everyone who are watching in.
Thank you, Dr. An, and all the student panel. As I had shared with you, during their presentation, I had emailed out to all the registered attendees a copy of the poster as well as the reference list. So with that being said, I know we ran over time a little bit, but I appreciate your patience in supporting the students. They are our future. So this concludes our program. We have an excellent panel speaker. I really, truly appreciate all the speakers, Dr. Brathwaite, Dr. Mann, Dr. Freeman, Ms. Davis, Ms. Manzo. This presentation was recorded, and I can feel the energies in the room. I can feel the inspiration, message, energy in the room. I hope this is the beginning, a celebration of Black History Month, but it is only the beginning. We will have follow-up similar seminar as more information available on vaccine as we move forward. I invite you, if you're interested, to please join, send an email to stay on our listserv. We will follow with you. But thank you so much for your time, and please join me in thanking all the presenters for today one more time. I know we cannot clap, but we can virtually clap for all presenters. Thank you for your time, and thank you for your support. Happy Black History Month. I wish you stay safe and warm in this cold weather. Take care.
Thank you.
Thank you. Thank you, Dr. Tron.
Bye-bye.
Thank you.
Thank you, Dr. Trump. Bye-bye.